Okay, so good
Yes,
afternoon
yes.
and welcome everyone. So we're glad to have you with us. So we'll officially start. We have around 104 participants so far. So thank you very much for joining us. I am Dr. Tadail. I will be your host for today, and I am joined with my colleagues, Dr. Israfil and Dr. Avenizar as well. They will be my co-hosts for this session. So before we proceed, I would like to say a few introductory remarks about Yetena Weg. So Yetena Weg is a registered in Pennsylvania, USA as a nonprofit, and it's run entirely by volunteer members. So it currently has 70 active volunteer members spanning across 5 different countries. So it had humble beginnings from 2 initial formers of the organization that has expanded over the years to include 70 active volunteer members. So as you can see on the right upper corner, these are all our volunteers. So our projects and engagements can be seen into 4 aspects. So the first is health promotion. So this is done with discussions and articles regarding the general public health as well as health policy and its implementation. So we're also engaged in community engagement. It could be slow blood drive, inclusivity or equity trainings or projects, inclusivity trainings, fundraising campaigns. We also have a mentorship and a skill sharing program. So there's going to be direct mentorship. It could be career and professional development as well as soft skills. And the last is our CME wing, or the CME and research QI projects. So Yetenaweg is more than a digital platform, so meaning our volunteers our volunteers also actively engage in several activities, as you can see in these pictures. So this is also another slide showing our volunteers in several of our engagements, including our inclusivity trainings, donations, as you can see from the pictures. So Yetenaweg also collaborates with Roha in a health writing article competition, along with IMSA. So the third round has already been completed. So Roha Medical Campus will usually award travel grants for 2 health article writing competition winners. So Yetena will also award pulse oximeters for the top 20 winners and litmus stethoscope for top 3 winners. And the top 5 winners will get internship opportunities at Roha Health and other institutions. So as you can see from the image, the left-hand corner is our 2021, and on the right side is our 2022 winners, and these are the 2023 article winners. So they got the opportunity to attend an event at the University of Global Health Equity. So having said that, Yetenaweg also collaborates with Roha Research Fellowship. So I'm sure most of you are aware of this. So it had a fellowship with Addis Ababa University Medical Faculty that started on the 14th of March. It included 3 departments, mainly oncology, radiology, and internal medicine. And research grants were awarded for the top 4 winners and mentorship for the other 10. This is also done in collaboration with St. Paul Millennium Medical College. So the difference from Kurambasas is mainly medical students or interns were the one that participated in this research fellowship. So research grant is awarded for 4 winners. The winners have been announced. So this is a slide showing the winners from the Kurambasa Hospital. So 1 from internal medicine, 2 from internal medicine, excuse me, 1 from oncology, and another from radiology. So our CMEs, as you all know, are freely accessible, and Yetenaweg partners with the Ethiopian Medical Association, Ethiopian Society of Internal Medicine, Ethiopian Society of Cardiac Professionals, other organizations to provide continued training for healthcare professionals. So we've had 9 CME webinars so far for the year 2024, and our average webinar attendees varies from 150 to 200 healthcare professionals. So for the year 2024, we've planned to hold at least 30 webinars focusing on emergency and surgical medical cases, ENT, pediatrics, OBGYN, on various topics. So we invite renowned local and international speakers. So you can access our previous CME sessions on our YouTube channel. And you can also get updates about our upcoming CMEs by joining our Yetenaweg Telegram channels. So for healthcare professionals, and by also following our social media posts, which we'll share shortly in the chat box. So to get the best experience in the webinar, you can send your questions on the Q&A or directly on the chat box. And at the end of the webinar, your questions will be addressed by the guest speaker accordingly. So to get CU certificates, as attendees, you must be able to fulfill the following set of criteria. The first is you must be able to attend the whole sessions virtually because the minutes attended will be checked via Zoom attendee reports. So you must be able to fill in the Google form for personal details and attendance, and you must be able to get 50% and above on the post-webinar quiz. So you might be able to see your result right away, but the certificate will take 1 up to 2 weeks. So the certificate will be delivered to your email in a 1 up to 2 week time span. So we ask that you wait patiently in the meantime. So having said that, I will directly proceed to introducing our guest speaker for today. Our guest speaker today is Dr. Nuru Mohammed. He's an accomplished obstetrician and gynecologist, as well as an assistant professor with more than 14 years of experience in the field. He attained his medical doctorate from Gondar University and senior medical specialist degree in obstetrics and gynecology with honors from Adam Hospital Medical College. Dr. Nuru is currently serving as an assistant professor of obstetrics and gynecology at St. Peter's Specialized Hospital. In addition to his academic role, he is actively involved in addressing gender-based violence as a trainer for governmental and non-governmental organizations. So he also mentors and supervises the one-stop center for gender-based violence survivors at Ekka Kotabe General Hospital. So with a strong focus on providing high-quality medical care, Dr. Nuru is experienced in managing healthcare services to meet the diverse need of patients. Furthermore, he has an extensive list of certificates and trainings in various areas of obstetrics and gynecology, demonstrating his commitment to continuous professional development and has contributed to research and various publications. So with that said, I will directly proceed to Dr. Nuru. So Dr. Nuru, please proceed.
Okay, thank you very much for the introduction. As you know, our main topic today is on the management of, gender-based violence. I think it's hearable, yeah?
Yes, it's feasible, doctor.
Yeah. Okay. So, as you know, gender-based violence is one of the most scenario that encountered in our community. There was research done almost a year and 2.5 years back in Addis and in Adama, and the occurrence of gender-based violence is usually at around 75%, both physical, psychological, and sexual. Always when we entertain gender-based violence, we always consider that only sexual violence was entertained. But we know that the most common cause of gender-based violence is the power imbalance. So there was research done with CEDAW, and it says around 33% of Ethiopian population, especially the females and the children, are more vulnerable for sexual violence. So having appropriate technique to evaluate the gender-based violent individuals or the survivors is very important in order to have our main intention is to have a fruitful society in the future. So on the clinical management aspect, on the clinical response and management, we have three topics today we need to discuss. One is the clinical assessment, the clinical management, and the follow-up. On the clinical assessment, we try to address how to take history, physical examination, and laboratory evaluation and forensic evidence collection. And also on the clinical management, like managing the survivors, what will be into consideration to evaluate, not only to have a management aspect. And the other very important issue is regarding the follow-up. So follow-up is very important because it's not like other medical cases on whom giving a single medication and return to back home. So very important thing is follow-up. Mind you, normally, not only the medical management, what is very, very important on parallel to medical management is the psychosocial support, which is very, very important. As you know, most of women and children who have vulnerable for sexual violence, they commit suicide, post-traumatic stress disorder, eating disturbance, and there are so many social and psychological complications. So knowing the clinical response and management is very crucial in order to have the quality of care. So our main thing is how to the principal approach for the gender-based violence. and also how to do medical assessment and physical examination, and also the laboratory evaluation, and how to understand the interpretation, and also regarding the forensic data collection. So, general consideration, normally there is a so-called life technique, which is very important, which is a very important technique called life technique. L stands for listening. Always you should listen. You should listen to the individuals or the survivors with empathy. Don't be judgmental and don't try to enforce them to talk about the history. So you should be a good listener. Usually we listen with our eyes, with our heart, and with our eyes as well. So listening is very important tool before history taking and physical examination. And the other is one of the most important thing. We need to know their need and their concern, and also we should validate them. Okay, validation is very important. Don't judge them, because judgment is not. It's a very it's not important, because they will not tell you the right history. So as we know, taking history and physical examination in children is very peculiar. So we'll try to see something regarding taking history and physical examination at the end of this session. So the most important thing on the general consideration is priority. Our main priority when the survivor came to our clinic or hospital is not checking the virginity. Mind you, virginity presence is not will not rule out violence. If a woman, or if a woman came with, complaint, and if you say that the virginity is intact, so having virginity intact is not, rule out, it doesn't rule out violence. So violence can occur with intact membrane. So, sorry, violence will occur with intact virginity. Okay, so our main priority is the health of our clients. Okay, the health of our client. If a woman came with bleeding, if the woman came with severe pain, and checking only the virginity and send her home is not the right way of approaching. So our main priority is the health and the care of our, the health and welfare of our the clients. Okay, so what will be the setting? Our setting should have to have some peculiarity, like the so-called one-stop center. As you know, one-stop center is designed to serve sexual violence. So it will be run by Ministry of Justice, Ministry of Health, Ministry of Women and Child Affairs, and even in center like a federal police. So this ministry levels will have a mandate to run the one-stop center. So the one-stop center, a main aim is if the survivor came to our hospital, she should have a one-stop. Like evaluation should be in one, and also the psychological support will be there, and the legal officers like police and the legal attorneys will be there. So all things will be held that on the same side. So the so-called one-stop center. So if a woman came with violation by her stepfather, if you treat her and return back to home, it's not feasible. So there will be a waiting house, which will be done by, some non-governmental organization, and some with the ministry in collaboration, like outside, they will have safe house. Things will be planned with the cases. Okay, so our main priority, as I said, is the health and the care of, the health of our clients. And the setting, it should be one-stop center. One-stop center. So you all currently, it is one of the indicators to be evaluated by the ministry at the hospital level. So all hospitals should have a one-stop center. If you're not able to prepare the one-stop center, they should prepare the case management of rape on their side. It should be isolated from other clinic, like antenatal care, like safe abortion, or other MCH. OPD should be away from that. So the setting, our main intention is to have a one-stop center on all health facility. So regarding the timing is very important, because if the survivors came immediately, there are so many advantages. One, we can have, some evidence, like forensic evidence, can be collected within 5 days. We know that collection of the forensic is our main intention, it's our mandatory. the health professionals are mandatory to collect the forensic evidence, but interpretation is not our mandate. The interpretation will be detected by or done by the forensic medicine specialist. So if the survivor came early, the forensic evidence will be available one. If there is any fresh tear or trauma can be detected easily. And the other thing, if the medications like the post-pill or PEP or other medications like for prevention of sexual transmitted infection will be availed. So timing is very, very important. If a woman came after 5 days of violation, the hymenal tear will be old hymenal tear. So we may not find some evidence for even for the legal aspect. So timing is very important. And the other is the ethical issue. Our main intention on the ethical consideration is do good for our clients. Don't try to write history on the side of the client or on the side of the perpetrator, okay? So you should document what you find. If without documentation, everything gonna be calculated by multiplied by zero. So documentation is very important. So we should engage with our ethical practice that all the medical doctors, they know about the ethical consideration. So on the initial history taking and physical examination, as I said before, listening is very, very important. Don't insist them to talk about the history until they are ready, because on the initial aspect, on the initial appearance, they will be on the genial phase. So don't insist them to talk about the history. So if they're not comfortable, the first thing is to have some psychological support and evaluation. So as I said before, listening is very important with our eyes, with our ears, and with our heart. So our main intention on the first step is assessing the general appearance. So when they came to the hospital, what about their gait up? Is there any gait abnormality? What about their shirt? Is there any sand, or is there any grass, or is there any, depending on the site of, if a violation? So if blue, and she's not, well, she may not tell you the history in detail. So our main priority, as I said before, is it's the health of the client, or the welfare of our client. And we should comfort and support the client. You can take the history, whether they may be in sitting position or maybe they're lying. Okay, don't insist them to talk about the history until they are ready. And also, consent is very, very important. One of the most important peculiar issue in evaluation of gender-based violence is regarding consent. Consent is very important when you are taking the history. Consent is very important when you are taking physical examination. Consent is very important when you are taking, forensic evidence and even the management aspect as well. So consent is very, very important. If the ages of our survivor is more than 18 years, she had the mandate to take the consent. But if the age is less than 15 years, according to our protocol, it says the guardians, either the mother or father, or the maybe those taking of her or him, should have a consent. But if the age is between 15 to 18 years, you are the one who decide for the consent, depending on the level of the consciousness of all the survivors. So that's a very, very important issue. And attaining any emergency condition. As I said before, if a survivor came with severe pain, taking history is maybe so difficult, so we should treat the emergency condition. But one of the most important thing is when you treat the emergency condition, you should take care of, don't lose, for not losing the forensic evidence. So there should be some preparation for forensic evidence collection, and we try to discuss some detail regarding forensic collection in laboratory evaluation. So on the taking history and physical examination, as I said, its consent is very, very important. Consent is very important. So the consent has a single paper having some, arrows regarding whether she have a consent for taking history and physical examination, forensic collection, for photography, for forensic evidence collection. For all things, this should be signed on single paper. We don't have any consent form on each aspect. So only one consent form may be enough for all evaluation, management, and forensic evidence collection. So on the interviewer scale, it's not like other medical professions, like medical patients or maybe surgical patients. We know that this individual came to our hospital with breaking some stigmas, okay? they have a stigma from the community, from the family, and they were trying to convince themselves and have some evaluation to your hospital. So your technique is very important, the so-called solar technique. S stands for put the client on the squarely. I mean, we will have an evaluation on the table, I mean, in the chair, and have two chair with the evaluator and the survivor. So put the client on, I mean, squarely, and you should have open posture. Don't try to cross your arms or legs. So even the survivors, they try to, I mean, visualize, or they can understand the while you are taking the history, whether you are engaged or not. So open posture is very important, and you try to lean to the client, and this is a very important technique. It assumes that you take for some I mean, the clients or the survivors have more comfortable to talk about the scenario in detail without fear. And E stands for eye contact. Eye contact is very important. Don't try to put the eye on them, but having some eye contact is very important because it seems you are more concerned and you are ready to help them. So E stands for the eye contact, and R stands for relaxed. Don't be panic. Don't be emotional. We know we are human being. Like if a woman, like a 3-month-old came with violation by her stepfather or with her father as well, it seems it being more emotional. Okay, we know there are some evaluators or some physicians who are more emotional and having crying I mean, with more than that of the survivor. So that may not be feasible while you are in evaluation. So solar technique is very important. S stands for put the client. I mean, you should put them in squarely, open posture, lean to the client, appropriate eye contact, and being relaxed. So we should ask open-ended question. So open-ended question, don't close the question. Like, don't be judgmental. Don't ask a question like by saying like a mamu, a babu, or other name. You should try to call the survivor with a name and ask open-ended question. Like for example, if our client is Almas, what happened to you? Like you came to our hospital. So it is an open-ended question. Don't say yes or no. Don't ask the question for yes or no. They try to, they may cry. You should give them soft. And otherwise, don't interrupt them. You should ask open-ended question. You should be a good listener. You should be a good observer. Okay. Like once upon a time, there was one survivor who he assumed that he is the caregiver, but finally we found that he was the perpetrator. So always, if a survivor came to you, and if there is any unaccompanying, caregiver, you should be always take care that always the caregiver is not on a positive manner. So there may be a lot of scenarios. So you should be a good listener, you should be a good observer, and record other history. Like if she's menstruating, where was her last normal menstrual period? Because it's very important. Our main intention, by the way, our main intention is to prevent gender-based violence by primary prevention. But if the prevention, if gender-based violence occur, one of the most important thing is to have prevention of the complication. So we should ask the history regarding her last menstrual period, whether he is taking like some contraceptive, like condom or other contraceptive, if there is any bleeding or not, if there is any intoxication, or if there is any physical abuse. So all, including the social circumstance, should be detailed. You should question, you should have taking the history in depth way. The other issue is on the physical examination, you should have an informed consent. As we said, you should have an informed consent, and you should check from head to toe. There are some misunderstanding, and there are some on the different institution. One thing, the survivors came to the hospital. By the way, gender-based violence it should be managed on emergency basis. You should not appoint them on Thursday and Tuesday when the gynecologists or some seniors are available referral clinic, okay? Gender-based violence is an emergency. You should allocate some OPD, one or two OPD, maybe one OPD with, if possible, one stop center. If not possible, maybe OPD should be assigned for the survivors. So our main intention is not to check the virginity, mind you. Our main intention while we are doing physical examination is from head to toe. That is very, very important. If a woman has some physical violence, and you will add on the diagnosis like soft tissue injury, and which is very, very important for the client during the legal aspect. So from head to toe, you should take doing physical examination, either in clockwise or counterclockwise. So this is the inspection. So don't try to, neck the whole body. So you should cover below the umbilicus to evaluate the upper body, and you should cover the other way to evaluate the other part of the body. So you should be systematic to evaluate the survivors, not only for the genitourinary system evaluation, but also from the HANT to the CNAs. The whole parameter is very, very important. So on the sexual examination, we know that it is epidendum, okay? So this epidendum, it's usually the anteriorly symphysis pubis, posteriorly the perineal body, and laterally the labia majora. So we know that there are some four openings like scanning duct, the urethral orifice, and there are some Bartholin's glands, okay? So always when there is forceful violation, almost always there is a posterior hymenal tear on the side of forchete, okay? So if you find a posterior hymenal tear, almost always it is forceful violation. So even currently, we are more concerning on the females, but also there are male violation currently even in Addis and in other, like in Adama, or almost in Halibala, there are a lot of male violation. So we know that violation can occur at any time spot in any individual. We are not guaranteed, okay? But women and children are more vulnerable for violation, but almost all, irrespective of the age, are more vulnerable. So knowing the anatomical location is very, very important before doing any physical examination. So there are normal hymenal variation. We know that hymen is it's a membrane. The Mullerian duct with urogenital sinus. So the two parts usually have at the end they will have a membrane. So this membrane is called hymen. So there are different type of hymen. This is the so-called crescentic type of hymen. Okay, so this is the crescentic, which is the most common type. The white one is the hymen, and the black one is the vaginal orifice. So this is the crescentic, or it is the most common type. And if it is more circular around, so-called it is angular type. And this is the fimbriated or estrogenated in a woman who is menstruating. So this is fimbriated hymen. And this is the imperforated hymen. There are two types of imperforated hymen, as you know, like imperforated hymen with no perforation or maybe micro perforation. So if there is any micro perforation, pregnancy can may occur because the sperm cell can pass through this opening. But usually this woman came with primary amenorrhea, with the physical finding of a enlarged uterus with the bulged hymen. So our main management will be adenosis, cruciate incision. And there are some also subtator type of hymen. So there are more than 7 type of hymen. So with this, picture, it seems easy, but what you need is more of practical. So on the practical aspect, you should be more cautious to know whether the hymen is intact or not. The other, like as an example, so this picture, if a woman came to you with this finding, like if you see the back of, the client or the survivor is having this kind of injury, our main intention is the abrasion. It is an abrasion on the lower back from the round, rough surface. So this exercise or these pictures are very important because doing only genitourinary stim evaluation is not enough for the quality of care. We should have full physical examination. So if you find on the back of the client, like this is an abrasion on the lower back, so it seems more of the round surface. So interpretation is very important for, I mean, interpretation will be done by the forensic medicine specialist. So if you find this picture or if you find this client, it is a defensive laceration here. So I do know that if there is any fighting or if there is any trauma, the first thing that you have to is you should I mean have with protection with your arm. So this is the defensive laceration and bruising on forearm and hand. So it's a defensive laceration. And this is, as you said, it is a fibrinated or estrogenated hymen. And this is, I don't know, this is a hymen. So hymen will be explained by the o'clock. This is the 12 o'clock, and this is the 6 o'clock, 3 o'clock, and 9 o'clock. It's like a watch. So this is between the 5th and 7th o'clock. It is a posterior hymenal laceration. Okay, it's completed on the 7th o'clock. So it's a hymenal laceration. And this is, we know that the dark one is the vaginal canal and the white ones are the hymen, and it is the caranicule. It is the remnant hymen because of the frequent sexual violation. I mean, if a woman is sexually, I mean, frequent penetration, after repeat penetration, this is a caranicule. And the other is, see, this is the urethra and the vaginal orifice, and this is the hymenal, I mean, the posterior forchete. We know that forchete is, it is a site for doing the so-called episiotomy. So it is a posterior hymenal and linear laceration. So this posterior forchete laceration, we say here, lacering on the posterior forchete is suggestive for violation. The other issue is this is the hymen is intact, but it is rate, I mean, radius discoloration. So there is no any penetration, but it shows there is some trial on the penetration. So it is a bruised hymen, okay? It's a bruised hymen. And this is some laceration and some bruising on the anal canal, I mean, on the anal canal. So it's a perineal bruising and laceration, which may be evidence for sexual violence. The other is, it is a fingertip, okay? This is a fingertip. It shows the perpetrator or the suspects have a violation on the upper part. So it is a fingertip, and she was below on during the violation, or it is a fingertip region. So there are some individuals who have some fingertip, or if you have some trauma on the upper extremity or the lower extremity, there are some bruising. So this is a fingerprint on the upper arm, and it is very, very important for the forensic medicine specialists to know the circumstance of the violation. And this is the trim liner also. So there is some physical violence why there a violation. And as you know that violation, it doesn't only sexual violation, so physical violation also may occur. So this is the bruising on the inner upper part of the skinned woman, like dark skinned woman. So even if violation can occur orally, okay. And the other is, it is physical violence. So there you see the right eye, there is ecchymosis, and there are some laceration. So it is a physical abuse, multiple bruising, laceration, and ecchymosis on the left eye. And the other very important thing is here, this the last picture. And on this photograph, it is a physical violation, we know that, but we don't know whether it's violated or not. Mainly, we should evaluate in depth, but there is some dark on the upper part. It shows wound healing, early wound healing. So it's a bruising in early wound healing stage. So our main intention is our main evaluation while we are doing genital evaluation is not only doing GUS for checking the virginity. You should check from the head to toe, so evaluation should be in depth, okay? So the other is the laboratory investigation that we know, even if consent is very important, and on evaluation, as I said, urine very important because like checking urine for the pregnancy, and also blood may be very important. Like there are some things if they have severe bleeding, you need to transfuse them. So blood group, you should know the name blood group, or like CBC is very important, and stool examination depending on the scenario, like if there is any violation anally, and also sample from any fluid that you find from the finding. If you find any fluid or from the vaginal fluid sample, like from for syphilis, gonorrhea, and chlamydia, and we should take at least two samples. And one is for our purpose, like if there is any sexual transmitted infection or not, or if to check for the so-called the semen analysis or sperm cell or any phosphatic acid which may be suggested for semen. And the other very important thing on the second sample is for forensic evidence. So forensic evidence, you should take the forensic evaluation at the same time while you are doing the physical examination. So when you are doing physical examination, you check for the virginity is very important, and you should take sample at the same time. Two sample, one is for our clinical care, the other is for forensic medicine evaluation. So even blood is very important for taking HIV, hepatitis, and also pregnancy test is very, very important. So this is a way how to take the sample from the vagina. We blindly, currently the recommendation, depending on the WHO, 3 samples should be taken from the upper vagina, from the lower vagina, and in deep vagina. So you should take 3 samples, but our protocol says 2 samples is enough from the inside vagina, from in high up and from the outer part. And you should take any sample if you find any fluid. And this is how to take a sample from the gingiva. And you know, there are sperm cell can take for about 24 hours in the gingiva, and also for 6 days in the vaginal canal. So if a woman came with a violation or orally, we should take sample. So our one-stop center should be capable of doing some sperm analysis or phosphatidylic acid detection for the evaluation purpose. So as I said, forensic evidence collection is very important. So injury evidence, as I said, if there is any evidence that should be documented very well, and if there is any foreign material, they should be collected with the plastic bags. And if you find any hair or blood for toxicology, and sperm and semen fluid analysis can be detected, because in vagina, as I said, sperm can occur for about 6 days, and on the anal canal, it can stay for about 3 days, and in oral canal at around 24 hours. Okay, so taking sample is very, very important. So this is all about the history taking and physical examination with laboratory evaluation and forensic evidence. So on the other part is the clinical care, which is the most important thing in the clinical management. So our main thing is how to manage the case with gender-based violence, and also how to interpret the physical examination, laboratory evaluation, and we should know the prevention and treatment of STI, and also the counseling session. Counseling session is very, very important. So if a woman or if a survivor came within an hour of the incident, if they came within an hour of an incident, there are some things should be sorted here. One is the physical injury. If there is any trauma, if there is any bleeding, we should out of the bleeding, and we should take some antibiotic. We should give some, like TAT can be given. So if there is any physical injury, we should repair, we should document, okay? Don't refer her because there is no any one-stop center. It is our mandatory to evaluate all cases of gender-based violence in our hospital, whether one-stop center is available or not. That is the recommendation. So if there is any physical injury, we should document the physical injury. Pregnancy prevention and management. If she's not pregnant, if HCG is negative, we should give post-pill. the main intention of post-pill is, as we know, post-pill is prevent pregnancy around 90% if it's taken within 72 hours, okay? So we should prevent the pregnancy as much as possible. But if pregnancy occurs despite our management, she had the right to continue the pregnancy, or she had the right to terminate the pregnancy, or after delivery, she had the right to take the baby with her or with other institutions, okay? So on the prevention of pregnancy, as I said before, the management aspect, she have the right, the full right to decide on the pregnancy. Depending on the Ethiopian Article 625, she had the right to terminate the pregnancy. So she had the right to terminate the pregnancy, or she had the right to continue the pregnancy. It's her consent, okay? The other thing is sexual transmitted infection. So we should give medications. We know that our main guideline on STI management and prevention is almost the same. So we should give them antibiotic depending on the protocol, okay? So sexual transmitted infection should be managed like other prophylaxis. And the other is on HIV/AIDS post-exposure prophylaxis is very important. We know that the current recommendation is 1J. So if a woman or if any survivor came with 72 hours, we should start her on PEP. Okay. Still, our protocol has no any topic on management of the suspect. Okay. Like for example, if a woman is HIV positive and if the suspect or the perpetrator violate her, and is there any management for the suspect? There is no any management for the suspect for per our protocol. But there are different protocols in Kenya. They have management of suspects. So even they were more concerned for the perpetrator as well. But in our setup, still we're not giving full service for the survivor. So in the future, hopefully, the ministry will include the management of suspect as well. The other is hepatitis B. If it's hepatitis B negative, so we should give her injuries as a vaccine. So there is no need to repeat it on the next subsequent follow-up. And the other is planning for safety. As I said before, if a child came with the violation by her stepfather, so if you give these all medications and management and return back home is not feasible. So planning for safety is very, very important. And sometimes we need to discuss in detail with the client alone. And other support, like legal support, is very important. So if a child have a survivor, if a child has some violation, so there may be some legal things to be entertained. So we should support them, like legal support, even having some social support as well. So this is the whole on the management of the first hour of the incident. But if there is any management, the management in the first 24 to 5 days, it's almost the same. But the only thing is, if the survivor came to you after 3 days or 72 hours, we cannot able to give PEP. But regarding post-pill, the current recommendation is it is very, very important for 72 hours. But if they came late after 5 days, still 5 days is possible. But if they came after 5 days, one of the most important contraceptive is IUD. So IUD is one of the main option for the prevention of the pregnancy as well. But the most important difficult scenario is the management of the kids after 5 days. As I said on the timing, the first slide, if they came late, the forensic will be lost. If they came late, we are not able to initiate medication like post-pill or PEP. If they come late, the forensic evidence will be lost. So after 5 days, usually the most important scenario is the psychosocial support, which is very, very important for the management of the survivors. So giving medication alone is not enough for the survivors to have bright and good quality in the next future of their life. So the other very important thing is follow-up. Without follow-up, all conditions will be lost. Okay, so our main intention on the follow-up is we may need to give. We know that we are giving medication, so whether they are adhere for the medication or not, is there any new scenario like with the issue of the PEP, then you have some night smear or some easy fatigability. So if they are adherent for their medication or not, is there any new thing? So on the follow-up, we will rewrite the history and we will re-investigate them, okay? And we will rewrite, we will re-evaluate them as well. So one of the most important things here is we will give them the referral form, the so-called affidavit report. And this affidavit report, the documentation, the medical certificate should be documented with 3 copies. One will be attached to the card, and one will be given for the client, and the other will be for the police officers. So the women have the right to know what's going on. So on follow-up, it's very, very important. So as I said, our main follow-up is to have an adequate documentation, adequate psychological treatment, or we should know whether they're adherent for the medication. So this is our main purpose of the follow-up. So regarding the schedule, the current recommendation is, the common recommended for the survivors is like for 2 weeks, 4 to 6 weeks, 12 weeks, and 24 weeks. Regarding the follow-up, like for physical injury, we should evaluate them on 2 weeks, if there any healing process, 4 to 6 weeks, 12 weeks, okay? For psychological support, whether they have any post-traumatic disorder, maybe a chronic sequelae, but either any depression, either any eating abnormalities, like, or if there any sleep disturbance, so we should evaluate them thoroughly. And even whether the pregnancy occur or not, we should check, because giving only medication like post-pill may not prevent pregnancy 100%, okay? So the other thing is even the social aspect. So not only whether they're adhere or medication is not the only aim of having a follow-up. So all parameters, all the management aspect should be followed with this recommended schedule. But 24 weeks is very important for the confirmatory HIV test, not for 3 months, okay? After 6 months, almost 5% of individuals will have a seroconversion. So at 24 weeks, we should do a confirmatory for HIV test. But if there is any emergency condition, if there is anything, we can break this scenario. So they can come at any time, at any time, 24/7. So our one-stop center, or our case management clinic should be available. It should be open for 24 hours and all 7 days. So we will appoint them with the respective weeks, but if there is any emergency condition, they can come at any time. So the additional visit can be scheduled according to the individual needs. So the other is the referral thing. One of the main intention on the referral is not only to give for higher, institution, as you know, in the labor ward, in a referral hospital, like for example in Black Lion Hospital, if there is any labor ward, if there is a normal labor, we can refer her to the health center. So the main intention of referral is not only to have quality of care, so the main intention is to have quality of care, but it may be vice versa. We can refer her to other setup for in need, like if a woman has some eardrum perforation because of some physical violence during violation, so we can refer to ENT specialist. So referral is very important, but the most important thing is while you are doing referral, the confidentiality and the privacy should not be broken. One, and the other thing is the forensic should not be lost. So for effective referral, the individual or the health professional should know about the problem very well, and whether referral is very important or not, it can have cost on her life or not, either any additional benefit for referral or not, and also her consent also is very, very important. So referral is very important if some medical problems were not managed in your facility. The other is documentation. Documentation is very, very important. Documentation is very important. Without documentation, as you know, as health professional, if you didn't document anything, it will be multiplied by 0. So documentation is very, very important for all our clinical practice. That's one of our mandate, okay? So one of the most important thing in documentation has 3 benefits: for the provider, for the patient, and for the good clinical care. For the provider, it's main etiquettes. Okay, so if you didn't document, you didn't do. So that the main logo for the all medical professional. If you didn't document, you didn't do. So if you do anything, you should document. If you document, it will be multiplied by zero, as I said before. For the patient, it's very, very important because while you are documenting on the medical certificate, that will be the evidence for the client on the behalf of our side. Okay, that's why we are not calling. I mean, we are not going to the legal officers in court frequently because we are giving the some medical certificate. So giving some medical certificate is very important. So you should document all the finding, not only the virginity, whether intact or not, but also if there any physical violence or not. So it's also good for good clinical care because today maybe Dr. Israfil may be the one who evaluated her. For on the follow-up, Dr. Mohammed, we may evaluate her after some time. So documentation is very, very important for all, for health professional and for the patient legal pursuit and for good clinical care. So on the documentation, it should include some demographic information, even the result of the physical examination, the history, which is the most pertinent finding, history, test results. So on that documentation, like if you give some medical certificate for the legal officers and HIV is negative, so but it should be repeated after 3 months or after 6 months. Okay. So normally, if you have a one-stop center, the caring to give a quality of care for the survivor is so simple because there is a clear communication between the legal officers, the prosecutors, and also for with the psychosocial support. So, if in your institution, if there is no any one-stop center, your main aim is to have a one-stop center. As we know, for preparation of one-stop center, there is a center like you are not allowed to prepare one stop center as you wish. So there is some demand should be, some research should be done, like on your facility, preparing one stop center is beneficial or not. What would the case load look like? If there are any health professionals which are trained or not? So these all things should be encountered, and at least one clinic should be assigned for the case management of PrEP. So even if as I said before, all of you are not guaranteed for violation. So, for example, almost all are, medical professionals. So, assume that if one of you went to, home at the midnight for taking something while you are on duty. So, if you are violated by some individuals, well, hopefully you will not have, you will not be comfortable to be violated, to be evaluated with other clients. Okay, it should be isolated. So always you should be on the shoe of the client rather than giving some advice away from the client. So documentation is the important thing. So for the documentation, the chart should be strictly confidential. Uh, our main, on the human right approach, one of the most important thing is having privacy and confidentiality. So those who work on the one-stop center have no any mandate to talk about the client. On other side, there are some individuals that are oral incontinence. They try to talk about the client here and there of the hospital. So that is a breaking confidentiality. So, but those who work on the one-stop center, on the legal officers, they may know about the case. That is not, that is acceptable. But we should be strictly confidential regarding our storage. So in someone's stop center, they try to have a chart, a separate chart from the normal, the card office. So they prepare like 001, 002, 0034. So it should be allocated only for one stop center. So that's maybe feasible. And the other, if there is EMR, so those who started electronic medical record, you should have a private password to locate only to be visualized by those who are responsible to evaluate the survivor. So confidentiality is very important because I don't know, breaking the confidentiality maybe legally we are legally accountable. Okay. So information should not be disclosed to anyone. Okay, information should not be disclosed to anyone. Sorry, information should not be disclosed to anyone except those directly involved or caregivers that required by the local stat and national status. So the other thing is, as I said before, collecting forensic evidence is our mandate. Okay. Currently, there are some forensic evidence, specialists in some institutions, and still there is, forensic medical laboratory, which may be so expensive, already start working in Addis, but still there is a negotiation or a discussion with Minister of Health and Minister of Justice regarding to use that forensic evidence laboratory with gender-based violence clinic. So it's on process. Maybe in the future we may have some opportunity to evaluate the forensic evidence. So the other thing before closing the session is evaluation of, children. We know that children evaluation is totally different from from the adult. Okay, like if a child came to you, sometimes we need to evaluate with anesthesia, evaluation under anesthesia, EUA. So first thing, psychological support is very important, and uh, when we are taking history and physical examination, we should have a good relation with the client, especially with child clients. So you should talk to them in slow motion, and you may need to give some paper and like some arts, maybe some color. So color is very important. So play therapy is very important before taking physical examination for child survivor, because in child survivor, taking history and physical examination may be so difficult. So, but the management aspect and on the laboratory is almost the same, except like the urine HCG, for example. If a female survivor at the age of 11 or 12, if she not, have menses, so even if with that violation, she may be pregnant. So before menses, there may be some ovulation. So at the age of 10, 11, 12, if they didn't have any menses, better to give them post pill to prevent pregnancy. But the other, like the sexual transmitted infection, like PEP or other medication, is almost the same as that of adults. So this is all that I have, and if there is any question, comment, suggestion, you're welcome.
We have around 20 questions, and we will try to go through them one by one. So I hope you can see my screen, Dr. Nuru.
Yes.
Okay, so the first question reads, as we know, in many rural areas of our country, the health services are provided by paramedical professionals. So in case where any sexual violence or rape has happened, is it possible to conduct the medical procedures in these setups?
So thank you. It's a very, very important question. As you know, previously, the survivors can be, usually evaluated by the gynecologist, or if there is any, like if the age, if female violation by gynecologist, and if there is any male violation, like less than the age of 15 years, pediatrician, and more than 15 years, surgeon. That was the previous trend. But currently, the trend is already changing. For example, our main experience, like in St. Peter's Specialty Hospital, if there is any female violation, the OBGYN will be responsible. But if there is any like male violation, the pediatric surgeons will be involved. Okay, there are two brilliant pediatrician surgeons in our hospital, so they will chair 15 days and for 15 days. So male violation will be evaluated by the pediatrician surgeon. Surgeon should be involved because there will be prepared a material called anoscope, which will be very important for evaluation. As you know, in rural areas, most of our one-stop centers are almost not more than 15 in number. Okay, so those individuals, all medical professionals By the way, the current recommendation from the Ministry of Health and Ministry of Education is to incorporate gender-based violence on the curriculum, especially on the midwife curriculum, on the nurse curriculum, and on the medical curriculum. By default, OBGYN chapter 54 is almost gender-based violence. So there should be no any training for evaluation of the gender-based violence. So if physicians like HO may evaluate the gender-based violence with training, medical professional with training, the current recommendation, but the other paramedics, it may be so difficult to have a good quality of care. But in the future, if the GBV evaluation and management is incorporated in the curriculum, almost all health professionals who are out from the university will be more capable. So still, but currently we are evaluating the pediatricians or the surgeons or pediatric surgeon will evaluate the male violation, but the gynecologists or well-trained general practitioners can be practice this gender-based violence even on the legal aspect. So they have the right to evaluate gender-based violence depending on their level of education and also with the training as well.
Okay, thank you. So I believe you've also managed to address the second question. So I will directly proceed to the third. So the third question reads, so if a survivor of a sexual assault becomes pregnant, even after taking contraceptives, what will be the next step in the management?
She had the right. I do know. Even if she came late, we are not able to provide contraceptive. I don't know. And even if you give post-pill, the possibility to be pregnant is around 10%, even if the issue of ectopic pregnancy will be there, especially if it's not taken before ovulation. So if she become pregnant, she has the right. What we will ask her, we should have a consent. Do you want to continue this pregnancy or do you want to terminate the pregnancy? If she said, I want to terminate the pregnancy, she had the right to terminate the pregnancy with misoprostol and with any other medications. If she have the right to continue the pregnancy, she has the right. If she consent for, I will continue the pregnancy, she has the right to continue the pregnancy. And after she decide to take baby with her or give to other individuals who can for the baby. So she has full right to terminate the pregnancy or to continue the pregnancy.
Thank you. So the first question reads, why is the confirmatory test of RVI performed after 24 weeks? So based on the person who has raised this question, their prior information is that it will be conducted after 3 months or 12 weeks.
Yeah, currently 2021, the WHO recommendation, there is a late seroconversion after 24 weeks. So our main intention is not to meet the finding. For example, if a woman have a violation and if it says like HIV negative, then after 3 months, if it says HIV positive, documenting HIV positive for the legal prosecutors is very important. That will have for the legal purpose, they may strengthen the penalty for the suspect. So current recommendation, depending on the WHO 2021, it says by the way, I presented the document 2016, Ministry of Health, but currently we already revised the document almost 15 days back. So hopefully those who will be involved on the training we will give a training on the new, document. But the current recommendation, it says not 3 months, it is 24 weeks.
Okay, thank you. So the fifth question reads, what would be the scenario when the survivor shows up days or weeks after the assault? And what are the possible findings and how would it affect the medical legal process or the follow-up activities?
Yeah. Yeah, the management is totally different. If a woman came within first hour, or within, if they came within 5 days, there will be a forensic evidence can be collected and to be evaluated by the forensic medical specialist. You will find some tear, like fresh hymenal tear, or some any other finding that will be documented for the legal prosecutors. And you can able to give some medications, which is very, very important for the prevention of HIV and some sexual transmitted infection. So if they came late, whole things will be miserable. If they came after 5 days, the only thing that we can give them is like prevention for STI. We know that Some STIs are usually the half-life almost the incubation almost 3 days up to 90 days the incubation period. So for the first instance, if a woman even violated by some individuals and if they come to your clinic and if says VDRL is negative, it doesn't mean it's negative. It may not be negative. So it should be repeated after somehow. So the time that matters, that's the time that matters. But when we have a finding documentation, don't try to recur to a documentation called REP. REP is not a medical terminology. REP is it is a legal word. Don't try to mention anything. Our main intention is our main mandate is to document what was the history, pertinent history, to document the physical examination, which is pertinent physical examination, and to have a finding, old hymenal tear, fresh hymenal tear, or something else. And otherwise, REP is not our legal, I mean, it's not our mandatory to document. It's not a medical word by default. REP is whether the individual is raped or not, it is a mandate for the police or some prosecutors. It's not our mandate to check whether the woman is violated or not. Our main intention is to document what you find on the while you are doing physical examination and history.
Okay, thank you. So the sixth question reads, if a woman or an uncentered individual, a pediatric age group ranging from 2, 3, or 4 years, how can informed consent be taken? Because sometimes the perpetrator could be a family member. So in this case, how is informed consent taken?
Yeah, perfectly. That's a very nice question because I encountered this scenario. While an Adama one-stop center, there's a 6-year-old female, child, have survived, came with for evaluation, and there was some individual who was accompanying with her. By default, if you are a good observant, you may see whether this caregiver is a real caregiver or it is a perpetrator. So if a woman, a survivor, if the caregiver is in front of her while he's walking, he is more of the survivor, it's more of the perpetrator rather than caregiver. So if you are in doubt, you may take him out and take history alone. I know it may be so difficult scenario. While you are taking the history for children, you should be so polite and tell them it's not their fault. It will happen on any individual, and you will believe them what they are talking about. If they're not fault, so if you are not judgmental, if they will be more frank to tell you the history in detail. So if you are in doubt, so I was working in one stop center for the last 10 years and I saw them very well. So if the survivor came with an accompanying, like children less than 15 years of age, so if you are in doubt whether he is a perpetrator or suspect or not, so if you are in doubt, you may take him out and you will take history alone. But taking histories, I know it's a very difficult scenario in children. So you should have some plain paper, A4 paper with like colors. So they will try to draw you. So art therapy is a very important management aspect in survivors, especially in children's. So one-stop center should have a play therapy for children. Sometimes if they are in pain, they may not, if they are in pain, they may not try to tell you the detailed history as well. So the consent, as I said, if the age is less than 15 years, and if you are in doubt whether the caregiver is a suspect or not, you may take him out and you can take history. That's you are the one who decide what are you going to do in the next step.
Okay, so thank you very much. So the seventh question reads, how can we manage sexual intimate partner violence according to the Ethiopian family guidance? Meaning, can one partner be punished by the law if he or she has sexually assaulted another partner?
That's a very important question. Currently, by default, we included the intimate partner violence on taking history on the recent revised protocol with the guideline. But the main important thing is still there is no any family law in Ethiopia to, or even in legal proclaims for the intimate partner violence. So still there is a great debate in the ministry level. like with the Minister of Women and Child Affairs and Minister of Health and the Minister of Justice. There was a great discussion for 1.5 days in Jijiga. So they finally, in the future, we may include the intimate partner violence. We know that intimate partner violence is one of the violations. It's gender-based violence. It's clear the Westerns and other African countries, they already included on the gender-based violence manual regarding the intimate partner violence, but still in our setup, as if yeah, depending on the scenario, like some phrase in Quran or in Holy Bible, like a woman will be obligated by the husband. You know the relation between husband and the wife with both, with spiritual books, you know that, but with the legal aspect, still it's not included in our setup. But in the future, they were trying to include. We know that even if she's his wife, if she has a sexual violation, if sexual intercourse without her consent, it is a violation. There is no way out. It's a deadly violation. But still, there is no any legal frame to evaluate such kind of case.
So thank you. So the eighth question reads, how can we manage regarding consent those that are below the age group of 18 if the survivors did not want the information to be disclosed to their guardians?
Depending on the protocol, if the age is less than 15 years of age, you should have a consent from the guardian. But if the age is less than 15, but more than 15, but if it is less than 18, the protocol says you are the one who decide on the consent. Okay, if they are mentally capable and if they are conscious, she had the right to have a consent. But if the age is more than 18 years, by default, she had the right to have a consent. But between 15 and 18 years, you are the one, those who evaluate the survivors can have a mandate to choose to have a consent or not, depending on the level of the consciousness.
Okay, so thank you. So I believe part of the ninth question has been addressed, but I'll proceed nonetheless. So most of the time, there are problems of using words on final assessment on part of healthcare providers, like using the terms rape, sexual assault, and violated. So if there's anything you'd like to add on this topic.
As I said before, rep is not it's not our word. It's not a medical word. It is a legal word. So if to say rep, the legal officers have the mandate, and otherwise, the only thing that you should document is what you're finding, either old hymenal tear, fresh hymenal tear, either any bruising or either any with diagram aspect and with mentioning o'clock. Currently, the legal officers, like the legal prosecutors, they will be graduated from their college after giving this training on gender-based violence. So they know what is 5 o'clock, they know what is 12 o'clock means. So currently, the ministry, not only the ministry, but also the federal police, they were having a frequent discussion annually and quarterly with their performance. So they were trying to assign the prosecutor and police to the one-stop center. So we know them very well, the legal prosecutors. So they have a training on gender-based violence, evaluation, and the legal consequence as well. So even they told you not to document a word called rape. So only the finding that we documented. So analyzing our document, and they will have some like our taking history physical examination, they have their own steps to check whether the violation occurred or not. So rape is not our terminology. Rape is the terminology of the legal officers. So don't try to mention anything about rape on the medical certificate or affidavit report.
Okay, thank you. So the 10th question reads, so does our guideline have topics on the management of perpetrators, as in providing psychosocial support?
No, not at all. As I said, like before, there is a protocol in Kenya, and I have a privilege to prepare some guideline and for management of survivors with the GIZ, and our one of the national consultant was from the Kenya, and that was Dr. Casey. And they said like they have prepared a manual for the management suspects. Like if a woman have HIV positive, and or if a man has HIV positive, and if it's raped by or if it's violated by an individual, so does he have any human right to be treated? Yes, yes, he had the right to be treated, but still our protocol didn't have any topic on management of suspect, not only psychosocial support, but also like some medical complications. So still there is no any include. It's not included in the management suspect in our protocol. But in the future, hopefully, if things are quite okay, we may need to consider about management suspect. But there was a scenario like if a woman become HIV positive after 3 months, and if the suspect is in prison, we will have another, court for trial for having HIV positive. So he will be asked, he will not be insisted to be screened. He have the right to refuse to be screened. Even the legal officers, even the higher officials have no any mandate to insist him to be screened, but he will be asked to be screened for HIV. If he says no, then the court says, indeed, he is HIV positive and purposely transmitted HIV to the woman. So he will have additional punishment. So that was the our trend in Ethiopia, but in other setup in Western, they have they have a management suspect. By the way, this one-stop center has the framework was from South Africa. In South Africa, they have a very beautiful one-stop center, not like us. They try to collect the forensic evidence, and they will have some in swimming pool and something for recreation purpose. And finally, after recreation purpose, like you will take history and physical examination. But we are far from this scenario. Even we are not able to prepare one-stop center in rural areas, and even we are not in a setup to collect the forensic evidence. So we're not accurate and good quality of care regarding one-stop center. But in the future, we know that since last year, one-stop center, gender-based violence is one of the indicator in the ministry level. So all the hospital leadership will focus on this management aspect. So hopefully in the future we may have some improvement.
Okay, thank you. So the 11th question reads, are the one-stop centers functional 24 hours and 7 days in our context? So if you could clarify further from your experience, and do you think that the survivors receive all the integrated services at one-stop center?
Yeah, in Addis, like Gandhi Memorial Hospital, Minilik, Ababish Governor, in Adama Hospital Medical College One-Stop Center, which is the best and one of the excellent sites. They were giving 24/7. But I know in other rural areas out of Addis, they're not giving. So the current recommendation to open the one-stop center, the EOC had the right to decide to open or not. The EOC include the Ministry of Justice, Ministry of Female and Child Affairs, Social Affairs. Currently, Social Affairs and Women and Child Affairs are already mixed and already merged. But the federal police, all this, the EOC they have the right to decide to open or not, depending on the case load, depending on the geographic location, depending on the catchment area. But currently, if you start one-stop center, not only one-stop center, case management rate, you should start 24/7. That was a real practice. GBV is an emergency. GBV should not be evaluated on referral clinic. It should be a separate OPD. If you have an OPD, one OPD may be enough. But to start the one-stop center, one OPD may be enough. In what our main experience in Adama Hospital Medical College, we were doing this job for the 5 or 3 years only with one OPD. I will be responsible for medical management, and Atomakonnen, his senior psychosocial support provision specialist, will be next. Then there is a police will be next. So we were using one OPD for all of us. But currently we were preparing one-stop center, which is a national excellence. So the current recommendation is you should work 24/7, and that was a mandate for the host that was given for the hospital. 3 months back, there was a meeting including the medical directors, genderist focal persons, and one-stop center to evaluate the one-stop center performance annual, quarterly. And the issue was that was a strong message from the directorate, from the Ministry of Health, is what was it should be opened 24/7, and still it was practiced in Addis.
Thank you. So the 12th question reads, what is the prevalence of gender-based violence in Ethiopia?
Currently, I have no any data, but 3 years back there was research done, and the gender-based violence, GBV, both physical, psychological, emotional, all include around 72 to 73%. But sexual violence alone account 33%, which is a big figure and shocking, because most of the survivors will not seek medical care because of the stigma. But currently, because of the social media, because of the burden, or because of there are some, the ministry, there are the Ministry of Health, there are some focal persons, including the health extensions. Currently, it was increasing. But the prevalence almost 3 years back, it was around 33% sexual violence. But currently, I didn't have any data.
Okay, thank you. So the 13th question reads, what are the drugs of choice for post-exposure prophylaxis and for hepatitis treatment? So if you could go over it briefly.
Normally, previously we were using 1E regimen, but currently 1G regimen. Okay, so for children, it should be calculated depending on their weight. Okay, so current medications are a little bit safer than the previous medication, depending on their nightmares and some psychological and somatomatic, some complications or adverse effects. They are lower, but we are using 1G. So it's depending on the weight of the, in children less than 15 years, but if it's more than 15 years, we can use the adult dose as well for 28 days. And for hepatitis management, still, if she is negative for hepatitis, we can give injuries at the dose, like at the vaccination, 0.16, that we're using for our prevention for hepatitis. But if the survivor is fulminant hepatitis, and if it is known, we can provide her immunoglobulin. So we know that immunoglobulin is a little bit expensive. It's cost around 5,000 to 8,000. But management says if a hepatitis negative, we can give injuries vaccine. But if the perpetrator or if the suspect is fulminant hepatitis, we can give immunoglobulin. But if she is become positive on the first incident, we can determine hepatitis B antigen, or we can determine the viral load, and still there is a place for viral therapies for hepatitis B positive individuals. But if she's negative, injects vaccine. But if the perpetrator is full-blown hepatitis, we can give her immunoglobulin.
Okay, thank you. I believe the 14th question has already been addressed, so I'll proceed to the 15th. So it reads as follows. Gender-based violence should be reported to who? And who should we report it, or how can it be reported?
Okay, that was a very, very nice question, and it's more practical. As we know, there is a legal phrase called if any health professional, if he saw or if he evaluates any violation, and if he didn't report the police, he will be accused for about, I think, if I'm not mistaken, 2 years in prison and 10,000 per, maybe, if I'm not mistaken. Anyways, we will be accountable. So if you find any violation, currently there is 911 call, especially in Addis, there will be a police will be arrived within 10 minutes. But if you have a one-stop center, if you evaluate a woman or a man with violation, by default, the police will have a word from the survivor. So that will be one part of the so-called report. So all violations should be reported for the police. Depending on whether the court to have, I mean, a legal aspect, if the woman, if it is less than 18 years, even if the family member or even if herself has not able to, or if she's not willing to read the legal aspect, the Ministry of Women's and Child Affairs would take the responsibility to take this other court. But if her age is more than 18 years, and if she has no any consent for the legal aspect, she had the right to drop the legal aspect. That's what the current recommendation. So we should report to the police, but creating the, I mean, the legal aspect or then a court is the responsibility of the individuals. If it's more than 18 years, she had a consent. If she had a consent, if the age is less than 18 years, the Minister of Women and Child Health, the Minister of Women and Child Affairs will take the responsibility to create the court. So we should report to the police. If you have a one-stop center, everything will be off. Everything will be, our responsibility will be discharged. Okay. For example, with my experience, when I was in Adama, weekly I was in court to explain some medical terminologies and some scenarios. But after we prepare or after we create, I mean, the one-stop center, every burden was, I mean, off, because with each case, we will have a great discussion with the police officers, with the legal prosecutors, and with psychologists. So everything will be cleared there. I called once within the last 5 years when I was in Adama with a case. Like the case was it was she was granted to Parawan mother, and she came for safe abortion to the hospital. I mean, to the one of the private clinic in Adama, and he inserted misoprostol, and he raped her or he violated her. He violated her. So there was a bleeding. So the courts want to have some explanation whether this bleeding is because of the violation or it is because of the medication. What is this medication? What is misoprostol? So I was having a 30-minute brief for the legal prosecutors and for the courts in the court. So if you have a one-stop center, by default, you already report the police. And otherwise, depending on the Ethiopian legal aspect, if you are not report the police, you'll be accountable.
Okay, thank you very much. So the 16th question reads, what is the legal and clinical definition of the term sexual penetration?
By default, as I said before, sexual penetration. Without penetration, there may be evaluation. I mean, there may be violation. Intact hymen doesn't rule out gender-based violence. Previously, when we see, I mean, whether the hymen intact, usually the perpetrator or the suspects are ahead of our evaluation, like previously we were checking whether the hymen is intact or not. But so they were using some lubricant to break that scenario. So even if the hymen is intact, they may have sexual intercourse. Okay, so I mean, recently taking sample from the vaginal discharge to check for the sperm motility and also the acid phosphatase. So they change their mind and they have doing the oral intercourse. So till recently, defining sexual violence with clinical evaluation, with laboratory evaluation is also difficult. So currently, still there is a possibility to check the sperm cells from the gingiva. So this scenario changed their mind for the perpetrator and they were using anal intercourse. Till recently, anal intercourse, it was so difficult to find the sperm cells. So currently they are using anoscope and evaluation by the most expertise. So currently they were changing their practice by only biting them without any penetration for their sexual pleasure. So our main intention is to document what were our findings. Don't try to document as rape. Don't document any sexual violation or sexual penetration. So even if there is no any penetration, still there may be violation. So whether the violation occur or not, it is the responsibility of the legal officers. It's not our responsibility. the problem of mainly our medical professionals or our medical doctors are they didn't know the legal aspect as well. One question: did you have anyone who read the civil service legal code on your hospital? Hopefully, almost all of us didn't know anything about the legal aspect. But if we know the legal aspect, we will be more protected while we are doing some uh, examination. We know that in obstetrics and gynecology, if you are indeed to evaluate a woman, you should have a chaperone. Yeah, if you don't have any chaperone, third person, if he says I was violated, she will be she the one who will be accepted by the legal aspect. So when we are doing a procedure or anything with gender-based violence, or maybe any clinic with female, we should have to have a chaperone, and we should have a clear documentation. And otherwise, we have no any mandate to say rape, or we have no any terminology to say penetration was there. The only thing is the finding, if there any sperm cell positive or not, if the hymen is intact or not. That's only our mandate and our responsibility.
Okay, thank you. So the 17th question has already been addressed. So the 18th question reads, what is the recommendation regarding TAT administration? So when after the incident should it be given?
Yeah, actually, if there is any physical violation, we should give. As it's almost the same. It's more or the same with our clinical practice. There is no any different idea or recommendation. But if there is any physical violation, we may have to give TAT, and otherwise only having sexual penetration may not be important. But if there is any physical violation, if there is any physical injury, we may need to give TAT depending on the protocol that we already using.
Okay, so I believe the 19th question has already been addressed as well. So there are a few questions remaining, the Q&A and in the chat box. So I'll stop sharing and briefly go over them.
Okay.
So another question reads, is there any standardized tool to assess the role of healthcare providers in helping gender-based violence survivors in their in the recovery process?
Yeah, definitely. There is a so-called TIER, TIER. All health institutions have the mandate to evaluate gender-based violence. Even so, there is a prepared manual on the management aspect, the so-called TIER, health post, primary health center, referral hospital, primary hospital, teaching hospital, what with their mandate on the gender-based violence. So there is knowing this TIER is very important because it's already the indicator. So if any survivor came to the hospital and saying we are not trained or saying it's not our responsibility, is legally accused. You will be accused legally. The most important thing that was raised previously was the psychosocial support. The psychosocial support is not an easy task in gender-based violence because those clinical psychologists may not be available in the hospital or in health center, for example. So if there is no any clinical psychologist which will be well trained on gender-based violence, we should have an appropriate referral. As per recommendation, the medical management is an emergency, but psychosocial support may be given on the nearby their residency to have an appropriate psychosocial support. So a fresh psychologist cannot address the whole thing within a single day. So you should have some training or have some experience. And otherwise, the most important thing is not starting medication for all post-traumatic stress disorder, for all depression. Medication is not important. So even if like psychologists will evaluate the psychosocial support, so if it is beyond the psychosocial support, we may involve psychiatrists as well. So one of the most important tool is knowing the gender-based violence steps and technique, not only in the medical aspect, but also in psychosocial support is very, very important. So each institution, not only each individual, but also each institution has a mandate to evaluate sexual violence individuals. And we all health professionals has some contribution for the recovery state as well on the follow-up. The most important thing is follow-up. Almost there was study done almost a year back in one-stop centers, and almost the main challenging is the follow-up. So if we follow them strictly and if they stick to their or adhere to the referral schedule, almost most individuals can be recovered. Regarding the issue of survivor versus rape, rape usually rape is not, it's not, you can change in WHO and in other UNSID protocols and document, you can use rape and survivor at the same time, but we prefer to have to use survivor because I know there are so many individuals. One of my best friend, she's a female gynecologist, she was violated at early her of age, and now she's a gynecologist. And I know there are some contractors were violated at their age, the younger age. So I think we can prefer to use the word survivor rather than rape.
Okay, thank you. So another question raised is, what are the complications that are common among survivors of sexual assault, especially in their adulthood?
Yeah, there are different complications. There are different complications, especially there are medical complications. Most of them, especially for females, they came with after they being married, they were having some sexual dysfunction. Okay, there is some sexual dysfunction. Even on the relationship, there is a big problem on the relationship. They are having post-traumatic stress disorder, which is one of the most complication one of the most complications, and even we know there are cases of the so-called uh, suicidal. There are a lot of suicide. You can go and check St. Paul psychiatric clinic. Okay, there are a lot of females who came with suicidal attempt, and even there are some reports from the legal officers regarding the suicidal attempt and even suicide. So there are a lot of complications. If we are not able to manage, like PID can occur, infertility, sexual dysfunction, even psychological traumas will be there. They're not happy with their life. So there are a lot of complications. So one of the most complications that I encounter is post-traumatic stress disorder, which they may not be engaged with any relationship, or if they start with the relationship, there may be some problem with the relationship.
Okay, thank you very much. So the last question reads, so most of the legal authorities in our setting require the conclusion that there is or there is no rape from the medical examination. So is it possible to conclude as such just based on medical examination?
I know this practice is totally outdated. Like there was some paper from the police officers. It says check the age of the victims and check whether the hymen is intact or not, and seal the paper with the document and send to us. That's the usual paper from the legal officers. But currently, all the legal officers have a training on gender-based violence. So if a woman says I was having violation, it is the mandate for the physicians to evaluate her without the consent or without a paper from the police officers. There are some physicians, even I know some gynecologists, if they didn't see any document from the police officers, they didn't evaluate. It's a mistake. That's a mistake, and that is legally accountable. So they know it very well. Don't say rape. It's not our terminology. Our main intention is our main to be upbeat for the our ethical consideration. You should do good for our client. Don't try to privilege her or don't try to privilege the suspect as well. So our main intention is to document what we'll find. Like history, pertinent finding, physical examination, pertinent finding, physical examination, whether it's fresh hymenal tear, old hymenal tear, or intact hymen, dead story. And otherwise, being violated or not, we know there are cases on whom she was violated, which is documented from the medical document, but the courts, they are not able to confirm that scenario and they may release us free. So our main intention, our main purpose to document on the medical report or affidavit report is you should document the finding, physical examination, pertinent laboratory, and final assessment. The assessment may be fresh hymenal tear plus soft tissue injury, or fresh hymenal tear or old hymenal tear plus STI, or no, otherwise, REP is not our terminology. I know it is a big problem outside of Addis. Still, there is a big problem because there is no any one-stop center. So the main important thing to have good quality of care is we should prepare one-stop center. If you have a one-stop center, a physician, a medical professional, plus psychological support giver, psychologist, plus social worker who prepare for waiting house, and the police and the legal prosecutors who will read each other, will have a great interrelationship. So if that's the case, this thing will be solved recently, I mean, in the future. But what I know is recently there were the recent graduated prosecutors and the policies, they didn't write this paper. It's totally outdated.
Okay, so thank you very much. So I believe almost all of the questions have been addressed. So once again, thank you very much, Dr. Nuru. So you've not only managed to cover the medical aspects, you've also walked us through the legal aspects in how to care for survivors of sexual assault. So thank you very much. And to all our attendees that have also participated in the Q&A, thank you. You've managed to raise very interesting questions. So I'd like to say thank you for that as well. So just to address some of your questions that are in the chat box. So there is no separate registration form. We'll use the quiz form. So in case you haven't filled it, there's a first section that asks for your credentials. We will use that as an attendance. And also, I believe another attendee has asked that they haven't been able to fill their middle and last name. So you can join our Yetenaweg for Professionals Telegram channel, and you can forward your queries there. We can address them in a timely manner. So there's also Yetenaweg has a website that is dedicated to sexual and reproductive health rights services. There are articles that are curated and reviewed by the Ethiopian healthcare professionals. There's also another podcast and training opportunities as well. So the link is being posted directly in the chat box. So in order to know more about this, please check the link that has been posted. So once again, thank you.
And everyone, before we end the webinar, I would like to say thank you again to Dr. Nuru, and there is one announcement from our SRHR team. Please join the Yetena for Professional channel, and on there you will find an announcement for a month spanning SRHR virtual training in collaboration with Yetena Weg and in gender health. The deadline was supposed to be today, but it has been pushed for tomorrow. This training cohort is the third one, and it will last a month, with 2 sessions being held per week. At the end, each of you will be rewarded 8 EU points and a certificate. So please do not miss this chance. You have 1 more day to apply. You can find the link for registration in the Yetena for Professionals page, and I would also post it here directly in the chat box. So utilize the chance. Once again, thank you for your active participation. This has been one of our most active sessions we have ever had. Would like to thank Dr. Nuru for this such engaging preparation and for his patience to answer more than 25 questions on this session. Thank you again, everyone. Good night.